going to move on to Tania Kalsi, who works within South East London system, who's going to give us what we've sort of done the national perspective, and we're going to hone in down now on a system, so ICB type system, and then we'll have some time for some questions. Over to you, Tania.
Thank you. So yes, I'm Tania Kalsi. I'm also a geriatrician in London, and I am the Ageing Well lead in South East London. So yeah, I'm going to talk to you a little bit about how we've started to try and implement all this change that's occurring at the centre in South East London. Next slide. Next slide. Great. So as Jagdeep alluded to, this is a really busy space at the moment with massive amounts of work done by parallel different groups. So you have to keep yourself very, very connected into these parallel pieces of work, because otherwise you come up with 5, 6 different plans which don't align. And in South East London, we're right this minute putting together our vision and framework for ageing well across South East London. In South East London, we have a sort of devolved approach. So each of the 6 boroughs actually are able to implement in their own ways. And that has some ability then to nuance to different populations, but also can make some challenges about having some common ground around what's the end game we're trying to deliver. So for South East London, we've been putting together a vision and framework for all the boroughs to align in terms of where we're trying to get to and how do we measure success that we've got there, and trying to think a little bit more around frailty at the population level and looking at what's success for mild, moderate and severe frail people, because clearly your outcome goals may be rather different. There are pieces of work going on, continuously around integrated neighbourhood teams, and clearly ageing well frameworks are in many ways the integrated neighbourhood team at its most complex. Long-term conditions clearly are common in old people with frailty, but they also need to create some frameworks without frailty for those in the younger groups. And the last thing we're trying to align towards is we're trying to move a little bit more towards population level outcomes and reducing some of those inequities that we see. And that can be quite an uncomfortable shift for clinicians, where focuses are often around one individual patient, and sometimes we may sacrifice the perfectionism for one patient in order to do good for more people. Next slide. This I thought was a really useful image from the National Associations of Primary Care, thinking about the INTs and the different parts that are important, and older people being one of probably the 4 big areas for INT development. As I alluded to before in the last slide, I think for frailty, it's about segmenting the population into groups so that you can target the right interventions with the right people for their particular outcomes. And that's whether they are severely frail, which may be the smallest cohort, but are the most those that use most health and social care resource, the moderate frailty group, where there's perhaps some scope for rehabilitation and prevention of progression, the mild frailty group, where it really has perhaps been neglected so far in traditional services, and where this is really with a preventative space and how we can prevent people becoming more frail too early. And also the fit and well population, which would lend itself to some blending with work that are targeting working age adults and preventing them becoming frailer when they're in post-retirement. Next slide. So what are we trying to cover within a framework that brings boroughs who are doing things slightly differently? Well, one is coming together with a clear vision, but also we're trying to not be just inclusive of health. I think we've just alluded to it clearly that we need to work much more closely with social care, but actually it's not just about social care, it's about the voluntary care sector. Big issues with housing, fuel and food poverty, community access to activities and engagement. And actually, we're bringing a lot more focus around how do you activate and increase your community assets, as well as being better sighted of your community assets, so you can really get communities working well for themselves, because the health and the social care bit really doesn't matter if the rest of it isn't working. We're taking a population level approach to targeted interventions, so right outcomes for the right cohorts. Your target for severe frailty is entirely different to that for mild frailty. Outcome measures, I think often because of the system measures that we have available to us, are often telling us outcomes such as length of stay or reducing hospital admissions and so forth. These are really important because we need to deliver value-based care. However, we need to find better ways of tracking resident level outcomes, population level outcomes, and outcomes for our workforce who are tired and exhausted and need to now try and evolve in a change process to enable to work differently, to deliver more in a different way, and that's quite difficult in a workforce that's quite exhausted. Next slide. We also want to find very good ways of dividing mild, moderate and severe frailty, and we're realising quite quickly that actually to find the mild preventative space is really very hard, and actually we need to work hand in hand with researchers to develop the right tools to identify those groups. And some of the way in which systems and ICSs can make themselves more sophisticated is creating that collective energy with their local research teams. I think we've identified that there will be key enablers, education clearly being a very important thing across the system in frailty specific training. I think we've spent probably the last 20 years developing multiple liaison services for geriatricians in various spaces, in the ED, in surgery, in oncology, in any way you can think of, in the medical wards, in the community. But actually we need to create a much bigger upskilling of the generic workforce to deliver the basic frailty care so that geriatricians can focus on the super complex. And that includes workers across all organisations. This is not just about health workers, this is about domiciliary care workers, this is about opticians, this is about your dentist, this is about care home workers, this is people in the VCS. So actually we need to come together as a system to align and work out what are the core elements of frailty we'll want the system to understand, and how do we deliver it in a robust way. Research I've mentioned. And then lastly, looking at digital and technology, as although we have a lot of different electronic systems nowadays, it's still clunky to align together, but also this group is rather more difficult to reach through digital methods. And whilst we need to align towards digitalisation, we do need to think about digital inequalities and whether this may make it even harder for the most deprived in society to access, so mitigating against digital inequity. So next slide. I won't go through this in detail, but we have a plan of action on how we can try and realise an ageing well framework through a series of workshops and stakeholder engagements, coming together with an aligned multi-system ageing well framework for South East London, which will then allow boroughs to map their current activity and where they need to make more progress. Next slide. I think it's really just to highlight there are different spaces we need to address, 1 and 2 being the much more preventative end of the spectrum, where we really need to ramp up activity whilst trying to manage that really very busy space of the peri-hospital interface in hospital at home services and virtual wards and intermediate rehab, as well as in hospitals. That's a difficult challenge for the NHS when you're really firefighting in zones 3 and 4, but unless we start putting our energy into zone 1 and 2, we're not creating a different future for ourselves. In fact, the future will become rather bleak indeed. Next slide. So we've been trying to align against the BGS blueprint. So looking at the way in which you can manage some of the recommendations of the blueprints around severe frailty and about how you deliver compassionate, coordinated care in near the end of life, how you deliver enhanced health in care homes, as well as actually thinking about other areas such as sheltered and extra sheltered accommodation, who perhaps the complexity more aligns to care home residents than domiciliary dwellers, how we design things around the interface for acute support and bringing that much closer to your proactive care space, so that rather than people stepping off cliff edges into different zones of care, actually you have seamless additions of bolt-on services that can be accessed as required. And then lastly, looking at population level education and how do you empower residents to self-manage. Things like strength and balance training and management of pelvic floor should be a standard public health message rather than something saved for clinical interventions once it becomes too problematic. Next slide. I'm just going to give you a real whistle-stop tour about some of the fantastic work going on in South East London and how people are trying to solve some of these issues at a place level, at a borough level. This is Lewisham and Greenwich, targeting the severe and moderate frailty end, and they're looking at how they develop their service, the PAWS service. So anyone who likes cats will love this. And actually, you know, they're targeting these people and making really good outcomes and reducing hospitalisation, outpatient appointments, reducing length of stay, and doing really super work. Next slide. This is the Greenwich Frailty team, similar model, built in the community, has a core frailty team using what they call case managers, who are multiple disciplines of frailty practitioners who retain their core elements of who they are, whether an occupational therapist, physiotherapist, etc., working with multidisciplinary team across different organisations, and again with similar outcomes to the Lewisham model. Next slide. This is in Lambeth and Southwark, where I work, and we're taking a whole frailty system approach, looking at how you can in-reach into existing structures such as GP practices, using data sets to manage your population into risk groups, and then put in the right level of support. So frailty team support around moderate and severe frailty, and psychosocial model and long-term condition work and mild frailty, but really recognising that actually some of the core work we need to do in influencing communities and managing loneliness. We're also trying to do a big focus around health inequalities by doing outreach work into specific vulnerable groups, as well as making every contact count in other settings such as housing, the faith setting, acute interfaces, as well as social care. Next slide. This is Bexley, and they've been doing a fantastic data-driven approach, looking at what are the specific needs of Bexley that are different to the other boroughs, and they are now focusing on their moderately severe cohort as their core target of where the greatest impact may be in the first instance. Next slide. And lastly, this is Bromley, and they're perhaps been the most developed of the INTs in terms of having this community MDM structure since 2017. And again, this has had a great impact on the management of moderately and severely frail older people. Next and last slide. So really what we're trying to do in South East London is pull together all these fantastic pieces of work across boroughs. And I think where we're broadly agreeing, and I think perhaps most would agree, that really we're trying to find ways to deliver person-centred holistic care, identifying people using data sets for risk groups so you can target resources and interventions most appropriately, as well as target the way in which you prioritise tackling this problem. Improve access to resources and joining up and building resources in your communities where it's not sufficient. And as well as creating the environment for change with education, for opportunities for research to build the answer to the questions that you really don't understand yet. And lastly, trying to look at what are the common languages we can use across the system for frail older people, because what we might mean in health may be rather different to a social worker, a voluntary care sector worker, or someone else. So can we create common language so that we're able to communicate and work together more better? And finally, I think some of this is about us understanding that we have some cross-cutting skills across different disciplines, across different types of practitioners, and can we as a system work out what those cross-cutting skills are so that we can create those savings and have increased trust regardless of which organisation that we work, that we trust each other to deliver the right care with those skill sets. I'll end there. I may have gone over a little.
Brilliant. Not to worry. Thank you so much, Tania. We will have time for questions for Tania and our next speaker. So I'm delighted to introduce you to Dr. Lucy Abbott,